Welcome to the webinar, Beer, Wine, Whiskey, and Patience, Simple and Helpful Clinical Talk. Hi, I'm Barbara Lewis, the Managing Editor for .com, an online communication skills learning system for medical schools, residency PA and NP programs, and hospitals, now that .com offers over 40 CME credits. Joining me is Dr. William Clark. He is a former Managing Editor of .com and the author of .com's Module 29, Alcohol, Interviewing, and Advising. Welcome, Bill.
Great to be here, Barbara. Thank you.
So please tell us a little bit about your background.
Well, you can see the bare details on the slide here, and I'll just add that I did my medical school and internship and residency work in city and county hospitals, and just watch constantly people dying of complications of alcohol and its difficulties, especially with delirium tremens, pneumonia, meningitis, and so on. And so once I got a little bit interested, those memories just kept me very, very engaged with working on alcohol problems.
So this has been a passion of yours for your entire life, almost, it sounds like, at least since medical school?
Absolutely, ever since medical school, yep. Boston City Hospital taught me a lot of lessons.
Great. So we're probably going to hear about some of those or the results of the research and things that you've done. I just wanted to talk to our participants for a moment and tell them that the webinar is going to last about 30 minutes. A recording and the PowerPoint will be available on the .com website shortly. And if you have any questions, you can type them in the chat box that's located in the panel, which usually appears on the right side of your screen. And if we don't get a chance to answer your questions during the webinar, we will respond afterwards. So let's get started, Bill.
Sure thing. I think like most of the modules in the psychosocial section, the advanced sections of .com, you know, you need to have this information at your fingertips. You don't need it every day. You just need it when you need it. And I'm glad that it's available. And of course, this webinar is in many ways a summary of that information. So I don't expect people to learn and remember everything that we go over today, and just remind them that it's available in the .com module 29. So just to start with a few comments, you know, dealing with people who drink too much definitely is a behavior change situation. And the key issues are being respectful, relationship-centered, and negotiating and summarizing. It's too easy to make a mess out of these conversations, and remembering the conversation issues that keep you being compassionate is really the key thing. I've got a little summary of the take-home messages here. We'll be going over those one at a time as the slides come up, and let's go on to the next slide. So alcohol really affects every aspect of medical care, and you know, a little bit of alcohol can cause lots of big problems, and of course a lot of alcohol causes terrible problems, and most of us are familiar with that from our own homes, the homes of friends, or even just simply drunk driving problems in our communities, if we haven't encountered them in the hospital and so on. So it's clear that we can make a difference, that counseling does improve patient health, and if we do it properly, we feel a lot better when we're doing it. I want to point out that although there are published criteria that provide clarity about the nature of problems and good ways to do systematic assessment, getting a definitive diagnosis may not be necessary to help people. We'll go on to the next slide from there. So over half of your patients will be abstainers unless you're in a very heavy drinking community. And it's important to remember and understand what a standard drink is, and that the way people organize their drinking and modulate it has to do with whether they feel good when they're drinking, whether they get bad hangovers, and of course, who's talking to them from the outside and making reprimands or criticism. Safe drinking is a key thing to understand, and the NIAAA has done a lot of work and brought together the research over the past few decades since I got started in this business. And it's pretty clear that drinking more than 14 drinks a week for a guy or more than 4 drinks in a day is not good for you. And for women, the limits are somewhat smaller. We also call that moderate drinking. And I point out that the term social drinking has no clear definition. It's not helpful in clinical settings at all. So at-risk alcohol use means the failure to consistently modulate your drinking. And it's just drinking more than safe limits. Those definitions are all clearly laid out in the DSM-5. And it's important to notice that about 30% of U.S. adults drink more than safe limits. We'll come to the data about alcohol use disorder in a moment. Suffice it to say that at-risk drinking, which actually is only slightly over the moderate amounts that we mentioned before, can produce terrible problems. So we just need to keep that in mind. So alcohol use disorder is what we used to call alcoholism or alcohol dependence. And I think this is a much more sensible kind of definition that is in use these days. People who have alcohol use disorder drink above safe limits, and the key issue is that it's the problems that they have that define alcohol use disorder, not the quantity of alcohol that they're using. So although we need to know something about quantity to make a careful diagnosis, it's the number and kind of problems that people have that are the key issues. So people with alcohol use disorder cannot consistently control their drinking. And typically, as is on the slide, they make excuses about their drinking. They blame other people. They find friends and partners who overlook intoxication, and they hang out with people who drink a lot. And again, with a definitional problem at the bottom of the slide, alcoholism is not a helpful word in clinical conversations. So the key issue about alcohol use disorder is that it is, in fact, a brain disorder. You know, we like drinking because of what it does to our brains. And even in small amounts, it changes our neurotransmitter systems in the ways that are on the slide there. But the key thing is that it feels good. So, gee, why don't I have another? And it eventually produces big changes that can keep people drinking when they know better and when people are saying they shouldn't be drinking more. I think if you've never seen people in blackouts, it's just an amazing phenomenon. I remember in the newspaper some years back, some famous person was missing for a few days, and they were found driving a car someplace in California. And the last place that they remembered being was someplace on the East Coast when they were last seen. And it turned out they'd been in a blackout for about a week. That is to say, they were drinking enough so that they were not making cognitive sense and not making memories. And when they finally came around, they had no clue where they had been. It's just important to understand that that phenomenon happens, and it's not infrequent in very heavy drinkers. And then, of course, when such drinkers stop drinking, they often get into the troubles that got me involved in the first place when I saw people dying in delirium tremens and having all the medical complications. But DTs is the result of all that suppression of neurotransmitter systems by alcohol suddenly being released when the alcohol is taken away and overcompensating. It's terrible. So we should always ask our patients about drinking. And of course, if they say they never drink, you're all set and don't need to do anything more. However, the next step for people who say they occasionally drink sometimes drink any of the alcoholic beverages. Ask men the, quote, single item alcohol screen, close quotes. Be very careful to use the words that are suggested. How many times in the past year have you had 5 or more drinks in a day? For women, it's 4, or men over 65, 4 drinks in a day. If they say once or more, that means they are very likely an at-risk drinker, or worse, of course. If they say they have never had more than 5 drinks in a day, or 4 for women, then you can assume with a fair degree of certainty that they're not in trouble with alcohol. And the parenthesis at the bottom of the slide is very important. Do not start by asking open-ended questions, which we're told to use in all other interview situations, like, tell me about your alcohol use, is just completely inadequate because patients respond with vague answers. Then we have to ask clarifying questions, and then people feel less safe and accused of lying, especially if they're having problems with their drinking. So don't use those open-ended questions. Use the standard questions that we indicated. So anybody who drinks should get screening, and we showed the single question screen. There is the full 3-question screen from the 10-question audit questionnaire. We'll come to that in a moment. And they're, again, very organized questions, which are the result of many, many years of research about how in the dickens do we help people tell us in a sensible way information that will allow us to be helpful to them, instead of the sort of random and open-ended ways that people were using in the past. So the audit questionnaire is a very helpful tool, which we'll show in a moment. But the 3 screening questions from the audit 10-question questionnaire are very helpful, and the scoring is shown at the bottom along with the sensitivity and specificity. So no screening test is perfect, of course, but this gives you an idea of where you're likely to go by using an appropriate screen. The next slide shows the audit questionnaire in all of its glory, all 10. We don't expect to have people read it now, but it's important to understand that this is the kind of thing patients can fill out in the waiting room by themselves, or if they're having trouble reading or feeling reluctant, a staff person can help them do it. So that you may, in fact, have the 3 questions that are the screen already answered when you're sitting down with the patient. And it's helpful to be able then to just go over the audit questionnaire with them and proceed from there. Of course, you wouldn't be likely to be using this in an inpatient setting, but one certainly could do that. Let's go on to the next one. So if the audit screening comes out positive, then a brief intervention should be done. And I know everybody knows at least a little bit about brief intervention these days, although that was not language in use when I first got involved back in the late 60s. So it's been clearly shown that a brief intervention, 5 or 10 minutes in the office or in the hospital bedside, is effective for at-risk drinkers. That means that some of them will in fact make changes after just that kind of intervention. Of course, a lot of others won't, but they'll be back for more if you've done it well, or they'll be ready to listen to the next person who has to deal with them if you've not caused them to get reactive. And we'll talk more about that in a minute. For people who have alcohol use disorder, the 5 or 10 minute brief intervention is really only a chance to talk about referral to a specialist, because we don't expect that the average clinician has the skills or the time to do the kind of counseling that's been shown to be helpful for those people who are seriously afflicted by alcohol problems. Let's go on to the next one. So I think the key thing about brief intervention is clearly, what is your counseling approach? And although it does increase the likelihood of successful outcome, it only does so if you're careful about it. And the general aspects include starting out, even if you're not feeling welcoming and empathic, to get yourself into that space. Take a deep breath, distract yourself in some way, center yourself, and get compassionate. Get ready to be helpful to this person who's having trouble in a way they probably don't fully understand. Be clear, be slow, be succinct, don't ramble on, and after you make your recommendation, close your mouth and open your ears so that you can hear how people respond. If they don't respond after, the usual 15 to 20 seconds, you might say, I wonder what you're thinking about what I just said, so that you can, in fact, be reflective and empathic with respect to their response, whatever it is. And that is the crucial element of successful brief interventions: remaining supportive and compassionate throughout, and never trying to persuade people of your point of view, reason with them, argue with them, and repeat 6 times your recommendations. That always hinders progress. And these principles have been studied very carefully over many years in a lot of different settings. So I just want to underscore those and ask people to pay enough attention so that you can do that when you need to. Practice. So it is clear that even people with alcohol use disorder are interested in changing. There's some part of most patients who knows that things are not well, and they're very seldom successful on their first attempts to change, just like cigarette smoking. But what is helpful is making multiple attempts and keeping at it, and finding a situation where you can get people who know what they're doing to make recommendations and stick with you until you get into a successful mode. So I think it's so important to just preface recommendations, I said, to be short and sweet and succinct, but start by using information that you have and keep it simple. Your weekend drinking is above safe limits, and I'm worried. Or if you have data, other data besides what they've told you, like blood tests or complications, these show that alcohol is hurting your health, and I'm worried. I recommend that we work out a plan for you to cut back or to stop entirely. What do you think about that? And listen reflectively, as I've been underscoring and emphasizing several times. And be sure that you say things that indicate that you are optimistic about what can be done, no matter how the patients are feeling at a given moment, and offer them options, which we'll discuss in a moment. Let's go on to the next one. So if patients agree that it's time to do something, make a specific goal with them of, say, something like, we share the goal of improving your health. Do you have a next step? See what they think about. And if they're talking about cutting down or quitting, you can make a detailed plan with them and make certain that you have specific action steps in mind. NIAAA website is very helpful, and they do have terrific handouts for patients, which you definitely should give them, because it's hard to remember all the steps that are appropriate, and it's hard to have enough reminders of what one should be doing. And be sure then that you see patients again in a very short time, and support and encourage them. Renegotiate as you need to. So if people are saying, no, I'm not interested, you want to, first of all, let them know that you heard what they said. I understand that right now you're not ready to take any active steps, but you want to restate your concern and say, it's a job I take seriously. I'm worried about your health, and make a couple of other suggestions. Restate your willingness to be helpful. I'm on your side. I've had experience about this, and whenever you're ready, I'm ready to talk about it some more. Let's go on to the next one. And if people, actually, no matter whether people are positive or negative in their approach, you definitely want to say that you're ready, no matter what happens, to work with them in the future. And I think it's helpful to say things like, there are things that we can do in this office that are hard to do elsewhere, and I can prescribe medications that we know can be helpful. I can refer you to professional counseling. The people down at Spring Street have been helpful to lots of my patients, and you can refer to mutual help groups like AA, and some of the dialogue is on the next slide. You might say, etc. I'm sorry, at the bottom of the slide, it says research and experience shows that certain medications can be helpful, and the ones are listed at the top that have been shown to be useful. So let's go on to the next one, which has some suggested dialogue or ways to comment about sending people on to referral. And it's just helpful language, very simple, straightforward. Remember to say, whatever I suggest may or may not be the right thing for you, but there are other ideas that we can pursue in the future. This is my recommendation for the moment. I hope you'll follow up. Many of my patients have done so and been quite surprised. So, golly, we whizzed through this, so we will have time for a few questions. So the key things here are, know about your patient's drinking, because alcohol in so many ways influences what you're doing with people's other medical problems, or even not medical problems. Even simple things like driving and pregnancy and using a chainsaw and so on are affected by alcohol and can get into medical problems. Remember that alcohol makes thinking difficult for people. Be sure that you assess people with structured screening and assessment tools, not just casual conversation that you might use with your friends. And be sure to stay relationship-centered in all situations. Learn how to do a brief intervention. It's pretty simple, but it takes a little practice. Especially, it takes practice to be quiet and to listen and respond very briefly with empathic statements before you decide what to do next. And then, of course, with people who have serious problems, you want to recommend referral, medication, and mutual help, and give all of your patients that have any alcohol issues the downloadable NIAAA treatment pamphlet. So that's what I have to say. This last slide is just a summary of the very many comments I've been making about being compassionate. It also says, years later, people will come back to you and say, my God, nobody else was able to be helpful. Nobody else listened to me. Nobody else was just there for me when I needed it without demanding that I do this or that or the other thing. Patients are very grateful for compassionately expressed concern, expertise, and clarity, whether they take action or not. You are unlikely to hear about it very often, but you should know in your bones that if you do it right, you're doing a very good thing, and that people who do get into recovery will be very grateful. Those who don't get into recovery at least will not have been steered in the wrong direction by your counseling efforts, which is all too frequent in other situations. So I don't think I'm going to bother with the rest of these slides, Barbara, and we can take a question or two, or you have some other things that you wanted to say.
Yes, thanks, Bill. This has been very interesting. I actually wanted to ask a question. I was at a lecture last night on precision medicine, and they talked about sequencing the DNA and the genomes and everything. And I was curious about the fact that alcohol is a brain disorder, which I did not know. And if there's anything in the brain regarding the genome that indicates that there would be a problem with alcohol. Has any research been done around that subject?
Oh my gosh, there's tons of research about the sort of the origins of the problem, and why do so many Irishmen have alcohol problems and so on. And it's clear that there's a genetic component, but to date, very little data or evidence about what that genetic component might be. There's some data, in fact, considerable data, on the why do certain populations not get alcoholism. For example, in many Asian communities and populations, the body generates, in response to alcohol, some chemicals that make people feel bad. And so it's an anti-abuse-like reaction. And so people don't drink. And so if they don't drink, they don't get alcohol problems. So we know something about why certain populations are free of the problem. We do know that there's a strong genetic component, but of course, lots of other things are important as well. And everybody's brain, if they get enough alcohol, does respond in terms of the neurotransmitters that we mentioned before, and the pleasure centers, so that everyone is susceptible because of those reinforcing properties with dopamine and other neurotransmitters. It's a little like, I just read in the newspaper a day or two ago about, not too surprising, funny thing, all mothers in all cultures respond in the same way when their babies cry. They pick them up, they talk to them, they hug them, they coo, and so on. And that's hormonally based. Well, there's a lot of stuff about how alcohol affects our brains, not necessarily hormonally based, but that is universal. And we can't escape those effects if we drink. So everyone is susceptible. I think one of the things that kept me interested in this, I'm part Irish, and I discovered somewhere along the way that I was drinking more than I thought I ought to be drinking. And I really, really liked it. I said, you know what, Bill? You could get into trouble with alcohol. And, this is sort of an eye-opener for me that I personally could be afflicted. And I think, as I've said already, most anybody can be afflicted if they start misusing alcohol. They can very quickly go sour. I'll stop there.
Oh, thank you, Bill. This has been fascinating and great information. If you want more information, check out .com module 29. A little bit about .com. As you probably know, there's a lot of evidence around the importance of communication skills. Here are some of them, including the HCAP surveys, which analysis has shown that the 2 communication dimensions actually drive the scores in the patient satisfaction surveys. .com has 42 modules that were written by leading faculty. We have over 40 CME and MOC credits, over 400 unscripted realistic videos, and any surveys that we do are loved by the learners. We have annotated interactive videos and a ton of faculty resources as well. The modules follow the same format. We start with a rationale, key concepts, behavioral checklists, lots of references. We have this wonderful feature of annotated videos where you can go through and what the clinician and the patients are talking about is highlighted here. And then if you click on the little icon, out pops the clinician telling you what he's thinking about or she's thinking about. We also have comprehension scores. This one happens to be on empathy understanding, where the user takes a test to determine where they think or identify where they think an empathic comment should be made. This is fascinating. And here's another one on facial recognition, asking the user what is the face emotion that's demonstrated here. We have lots of resources. And if you are interested in a free 1-month trial subscription to .com, use the code here, WebOCT17. So thank you, Bill, for talking with us about this very important topic that's been your life's work. I really appreciate it.
My pleasure. Absolutely.
And thank you. And thank you to everyone who has joined us. The recording and the PowerPoint will be available on our website very shortly. And a free .com trial subscription, of course, you can get with this promo. So please sign up if you'd like. And thank you very much, everyone.